Huberman gets into all that. Academia, there's tons of studies on this. So, I think the main reason it's not adopted more often is they're just in the insurance model, right? They use the tool that's in their tool belt. And if that's not a tool in my tool belt, then I'm not going to talk about it, and I don't have time to do it. And that's where I see large language models and an evolving market allowing patients to get that education on their own. They don't have to wait to talk to a doctor, right? I will have a team of academics right there at your fingertips, proactively analyzing everything about you. And I would tell you, I talked about predictive, proactive, personalized, all that. Another one would be private. You do not want this data in the hands of insurance companies. Listen to what Gary Brecka was telling you. He worked for the big insurance companies. He worked to assess your all-cause mortality risk and the risk profile to the insurance company, right? And so if let's just say in a miracle world, all of a sudden, Blue Cross Blue Shield rolls out a large language model to streamline your experience, and they want to tie into your wearables. The last person you want digging through your underwear drawer is the insurance company, because they're going to use it to limit your care, to limit what they cover, and to kick you off a plan, right? They're going to know when the chronic disease is coming, and they're going to charge you when they know they can monetize you. And then as soon as you reach a state where they can't, and that's the dangerous side of these large language models, and that's the dangerous side of the tool. And so a sword in the right hands is, one thing, and a sword in the wrong hands is a whole nother thing.
Jesus. I wonder if they are trying to do that. I wonder if these insurance companies are trying to.
They're for sure going to roll that out. Yeah, if they're not already. And that's the problem. Like when you have an insurance-based model, and that's where I would tell you, maintain the car outside of the system, right?
And the insurance-based large language models are going to ensure that you stay on these treatments because that's where they're profitable.
Correct. So there's the insurance company, and then we broke this down last time. Then there's the pharmacy benefit manager. Pharmacy benefit managers are a middleman between the insurance companies and Big Pharma. Okay, and they were put in place to negotiate the price of pharmaceutical drugs for the average American, because so many drugs were coming into the marketplace. The government couldn't get to and decipher what drugs make sense, what drugs don't make sense, what should we cover, what should we not cover. So they allowed pharmacy benefit managers to do that. Within a decade, the big insurance companies went out and acquired pharmacy benefit managers. Within a decade from that date, the pharmacy benefit managers began to negotiate rebates to themselves, not discounts to the patient. Okay? So, yeah, that's where I was trying to go with this. When I talked about $244 million in fraud in the state of Ohio, how? Where's the fraud? And the answer is the margins are made in the mystery. The more confusing the insurance companies can make it and the more convoluted they can make it, the more profits they can make. They have only a handful of levers they can pull to make money. So let's go over that. They can raise your copay. They can raise your deductible. They can raise your out-of-pocket expense. That's one lever. They can drive down the price of a drug that they buy at a wholesale price point. They can mark up the coverage of your care for your employer. Okay? And then they tier price. The pharmacy benefit manager gives a tier pricing. That tier pricing is not based on what drug is best for you. It is based on what drug is best for their financials. And so they prioritize drugs in a tier pricing under the misnomer to the American people that a tier 1 drug is the best drug and a tier 4 drug is not as good, right? But the truth is a tier 4 drug is not as profitable because there's a lesser rebate. And so let's go back to the insulin example. The average price of this insulin is $381 is what the Senate Finance Committee found. $381 on, I can't remember if it's Sanofi, I think, was their price. Out of that, the pharmaceutical company got less than $40. So that remaining $200-something stayed at the pharmacy benefit manager. Okay, pharmacy benefit managers are making billions upon billions of dollars a year. They decide what gets covered, what goes on your insurance plan, what your copay is, what your deductible is, and they can move any lever at any time. So examples, let's go back to GLP-1s, right? The weight loss diabetes medications. Those are showing up on insurance plans as tier 4 with a really high price tag. Well, you look at that and you go, man, wouldn't insurance companies want to get rid of that because it's costing them a lot? No, because they're showing that the price of a GLP-1 is $1,300. They never paid $1,300. They paid a fraction of that. But then they go to the patient and they say, hey, this is a tier 4 drug. You have a 50% copay on this drug, $500. Okay, so they made their money there. They made their money off the rebate from Big Pharma. Then
so
they
the
come
patient pays more than they actually are paying for the drug.
Correct. That is what happens on most drugs.
And
that is
just
why I built a
copay.
compounding pharmacy.
Yeah.
And but even if they don't, let's say it's a drug that you think is covered. Okay. Maybe the pharmacy benefit manager got it wrong. A drug entered the market. They didn't know it was going to be a blockbuster. They miscalculated how this was going to play out. They have lever after lever they can pull. Okay, high margin drugs, they've gone out and bought pharmacies. So they own mail order pharmacies. And so what they'll do, like when I owned a pharmacy, Blue Cross Blue Shield, they literally said they owed me over $1 million for 1 month of shipping out drugs. I'd already shipped all the drugs to their patient. I'd already done everything. They come in and say, yeah, we're not going to pay you. We don't think you collected the copays or deductibles. Okay, well, we did. Here's all the records. I can show you how soon can you get an auditor out. We want to cooperate. Like, we're a small company. We need this money. It's 3 months before we can get to you. Okay, and then they begin to make it so hard for you to survive in their insurance model. And then you'll be sitting there and a couple months later, knock on the door. Hey, man, heard it's tough out there for these small pharmacies. You know, we're looking to acquire pharmacies just like you, right? They've gobbled up the lifeblood of America. They've put all these small pharmacies out of business. They now own most of these big juggernaut pharmacies. So even if CVS says, we only made $10 off that prescription, what did the pharmacy benefit manager make? Okay, or what is the pharmacy, your mail order pharmacy making? Lever after lever after lever. Then the last part of it is, my buddy who has MS, his MS treatment, I think, is $14,000 a month. We just met. I have 260-something employees across both organizations. We met with the insurance company. They're raising our rates because they claim they paid $14,000 a month for his drug, right? He had a huge out-of-pocket burden on that drug, but was happy because he thought, well, hey, man, it was going to be 14 and I only had to pay X. And then they never paid the 14 because they negotiated a rebate on the back end. And then they turn around and they mark up my insurance plan for all my employees every year, year after year. It is a profit-driven system, not a patient outcome-driven system. And so that's all I'm trying to hammer home with patients. When you say, why don't you take insurance? Because insurance is the crux of the problem. You cannot operate in that ecosystem and provide quality care. You can't. Everything's controlled. Everything's dictated. It's terrible.
And most people have no understanding or awareness of this. So there's no real push to fix this system. There's no real push to regulate and analyze all of these problems and what's the downstream effect of these problems.
Yeah, and I even hear clinicians talk. A lot of clinicians don't know. Like, a lot of clinicians don't even know about pharmacy benefit managers. The only reason I know is because I've been in every aspect of this business, and then I would get into it and I go, oh God, that's why that was happening. Okay, now I get it. Now I get the magic trick. I understand what you're doing here, how you're moving and shifting profits and monetizing disease states. So think about this. If I can monetize your diabetes, why would I cure or prevent your diabetes, right? And I know if I'm a bigwig at United or Cigna, that you're going to switch jobs in 3 years, and by the time that diabetes leads to metabolic disease and a cascade effect that puts you in a hospital that costs me more money, you're somebody else's problem. Or if I can stall it long enough, you're the federal government's problem. And so every aspect of healthcare is focused on that quarter, on that on that time frame. Another terrible example of surgery, and this is honest to God. I talked to my buddy who's a president at an orthopedic company. He told me he was sitting down with a surgery center about joints. And there's a new joint that they have, and it's more expensive, but the efficacy data of the long-term benefits on it astronomically outperform the other joint that this hospital system was using. He sat down with the CEO of the hospital, and he said, here's the data, 5 years out, here's what we're seeing, da-da-da-da-da. The CEO said, I don't give a shit what happens 5 years out. Swear to God, this is a call I had yesterday. He said he looked me in the eye, Brigham, and he said, if you told me that this joint will last at least 90 days and it's cheaper, that's all I care about.
Oh my
because
God.
all of their data and records and accountability are only on the first 90 days. Once you're out of that 90 day and you've done your little review and all that, you're off again and you're no longer a monetizable patient. And so too, when we talk about primary cares and what's happened, the same thing with pharmacies where they've been gobbled up by insurance companies if they're in the insurance model is the same thing that happened with primary care practices. The day of a primary care being independent and a free thinker is over. They're employed by hospital systems. Major conglomerates have gone out and bought up the primary care practice. Why? Because now they have the patient population. If I can get you at the primary care level, then I can control the referral of where that primary care sends you as we profiteer off your disease state. Okay, so you go to a primary care. Let's just walk through the same example I gave earlier, a methylfolate test. They never run that test, right? There's genetics. The methylfolate test tells me my genetics, but there's epigenetics. The choices I make every day impact which genes turn on and which genes turn off. If nobody ever has a conversation with me in my 30s about my hormone levels, about getting into the sun, about eating right, and you push me towards chronic disease because you wrote me a prescription to treat a symptom, and now I go through this system and I get cancer, that primary care is going to refer me to an oncologist. And that oncologist is part of that same system, right? And most people don't know this. 65% of an oncologist's income comes from chemotherapy, from the markup they're making off your chemotherapy. 65%. And I attached that link, Jamie, too, where it talks about this. So all I'm getting at is, Russell Brand said this, and he was spot on. Another guy who's not a clinician but understood what's going on here. If we make things about profits and quarterly earnings and big business and not patient outcomes, don't be shocked when we get phenomenal quarterly earnings and piss poor patient outcomes.
65%?
65. And I attached the link just so we'd have it.
So they have a financial incentive.
Yeah. So this is an article where they were trying to, the insurance companies were trying to incentivize them to use a generic in this instance, because this is one of those issues where there's no rebate and no way for the insurance company to monetize it. But it breaks down how much money these guys, 65% of an oncologist's income comes from that.
Wow. This is incredible.
And so I say all this again because I don't think that a clinician's to blame. I don't think that they're just operating in the system that they're given. They're playing with the playing field that's been set before them and the rules of the game that have been set before them.